Good morning, everybody. We're going to go ahead and get started. Thanks for joining us today for Treace Medical's Investor Day event. I'm John Treace, CEO and Chairman of the company, and it's really great to be here with all of you at the NASDAQ market site in beautiful New York City. Our disclosures here for today's event. Here's our agenda. We got an outstanding lineup of highly experienced foot and ankle surgeons here today. These are surgeons that all share a common passion of making bunion surgery better for their patients and also helping enable other surgeons across the country do the same. I think you're really going to enjoy these talks. You're going to get a ton of information about these new innovations, how they're advancing the standard of care, and how they're going to help advance Treace's leadership in the bunion market. From the company here today, we have Sean Scanlon, our Chief Innovations Officer. We have our CFO, Mark Hare, and we have our Chief Commercial Officer, Guy Guglielmino, present as well. I thought I'd start off with a little background on Treace Medical, why we exist, what's made us successful to date, and why we're so excited about the future we have ahead of us. This is a company that from the start in 2014 has been driven by a focused mission, a passion for improving outcomes for bunion patients. And in doing so, we went from a napkin sketch to over $200 million in revenue with essentially one patented bunion procedure that largely changed the way that bunions were evaluated and treated. And now, in 2025, with an established commercial team in place and a large customer base, we're entering the next growth wave of the company, launching our best-in-class comprehensive bunion solutions portfolio. Bunions are a really big problem, and they can become painful, lifestyle-limiting deformities for a significant portion of the affected population. And we believe the shortcomings of prior surgical procedures in the past, resulting in high recurrence rates and high patient dissatisfaction rates, has been a rate limiter to surgery. This said, we believe there's a significant opportunity to expand beyond the 1 million symptomatic surgical candidates as we develop even more effective solutions for surgeons, solutions that can bring faster recovery, improve cosmesis, more enduring corrections for patients, and then communicating the benefits to the clinical community. And we believe there's a real opportunity for us to double the business in the years ahead. We're currently around 3% penetrated in the symptomatic surgical candidate base, and with the technologies that we have today and those in our future pipeline, we believe we just need to get to 7 to 8% to achieve that milestone. Our company was founded on this realization that the vast majority of bunions have this overlooked, underappreciated third plane involved in the deformity, and the negative impact that the failure to correct for that frontal plane, that third plane, can have in driving high recurrence rates. With recurrence rates cited in the peer literature as high as 60 and 70% plus with traditional two-plane surgeries of the past, you can see why a breakthrough like Lapiplasty, being the first ever instrumented system to allow a comprehensive three-plane bunion correction to be performed in a reproducible, repeatable manner, fills such a significant gap. And that's led to the adoption of this technology by nearly 1/3 of all bunion surgeons by 2025. And since our first Lapiplasty cases in 2015, this company has been hyper-focused on iterating and evolving our designs, constantly making them more reproducible, faster, less steps for surgeons, and more recently, minimally invasive. And it's this iPhone product development model that we've employed, and then supporting our surgeons with great training and differentiating clinical evidence that's made Lapiplasty the gold standard for 3D Lapidus today. And now we're applying this successful model to address different categories of bunions with highly specialized solutions that can accelerate our penetration into the market. If you look at our over 3,100 surgeon customers today, with Adductoplasty and Lapiplasty alone, we believe we penetrated about 30% of their total bunion volume. And here in Q3, we're launching 3 new systems, our Nanoplasty and Percuplasty 3D MIS osteotomy systems, and our Speed MTP Great Toe Fusion System. These 3 new offerings address significant volume segments, giving us greater access to the untapped 70% of our surgeons' cases, while also allowing us to appeal to a much broader surgeon audience. And we're leveraging platform technologies and to bring even more breakthroughs to market, like our market-leading speed plate fixation technology and our first-to-market IntelliGuide PSI technology for bunion and midfoot deformity correction. And today, we're announcing the initial introduction of our new Percuplasty MIS power system. This is a power system that powers the single-use cutting burrs that are used in the percuplasty procedure, but can also be applied to a variety of other minimally invasive foot and ankle procedures. This specialized new addition to our line cements our commitment to becoming the one-stop shop for all of our customers' surgical bunion needs. You're going to hear more about all these exciting technologies and innovations and even more coming up next from our surgeon experts and Sean Scanlon. We got an incredible panel of surgeon experts here today to help out. Drs. DeCarbo, Easley, Johnson, and Kaplan. Thanks again so much for being here to help educate this audience on these exciting technologies, the impact they're having on your patients and on your practices. And with that, I'm going to turn the floor over to Dr. Will DeCarbo. Will.
All right. So the green, is that what you advance with?
Go green.
All right, fair enough. Thank you, John. Well, I appreciate being here. My name is Will DeCarbo. I'm from Pittsburgh. My brethren will be here in about 4 days. That may or may not make you excited with the Jets and the Steelers, so the return of Aaron Rodgers, but we'll get through it together. In any event, my charge here is to talk about Lapiplasty and Adductoplasty, two of our flagship and main procedures and founding procedures with this. And again, just like John said, we're super excited about this technology, not just for today, but tomorrow. We continue to iterate this. As it was stated previously, when we look at bunions, there's over 130 different ways to treat a bunion. And the way we looked at it from a company standpoint at Treace, there's not one good way. Early on, we understood this, and we understood that triplane issue that we'll speak about again. I'll show you the slide that John presented as well. But in 2018, we proposed a classification system that kind of revolutionized the thought process behind what we're seeing when patients present with a, quote, bunion. Because there were 4 distinct categories of patients that presented with bunion. There's mild to moderate, mild to severe, metatarsal adductus, and arthritis. And the arthritis is really branched into 2 components or 2 buckets. There's arthritis with a bunion, and then there's a primary pathology of arthritis of the first MTP. The speed MTP, which Dr. Easley will talk about, covers both of those, and we'll go over that with you. One of the things that we wanted to do was to create a system. It was a philosophy change and an instrumented system in order to address each of these 4 subcategories, if you will, of quote-unquote bunion or, midfoot, forefoot deformity. And then with that followed what we feel is a best-in-class fixation options, and we'll discuss that. For the mild to moderate, we have nanoplasty and percuplasty. You'll go in depth on that with Dr. Kaplan and Dr. Johnson. For the mild to severe, we have Lapiplasty. That was our flagship procedure and really the springboard into these other technologies and these other midfoot, forefoot deformities. Metatarsal adductus we'll discuss, and then the speed MTP for the first MTP fusion, which Dr. Easley will go over. And the bottom, as this does the intraoperative C-arm as well as the cartoon drawing, just shows you the power of this system. So what we want is reproducible, consistent, triplane results with fixation that is best in class. And that's where we think we've landed, and that's what we're excited to present here today. The Lapiplasty, as said, our flagship procedure, one of the aha moments, and John kind of touched on this, was the frontal plane. The frontal plane's been described since the 50s, but until Treace Medical Concepts, nobody has really come up with a dedicated way to assess it and a dedicated way to fix it, and that's what we've done. The transverse plane is kind of intuitive. So the cartoon drawing here where you see the bump, we can understand that there's a transverse plane deformity, and that's the prominence. And what's really interesting about it is, there's a common misconception that's a growth or a bump and you can just shave off a bunion. The reality is the midfoot joint is unstable, and that allows that bone or that metatarsal to drift out of alignment, creating that prominence, and then the big toe kind of deviates to the lesser toes, and that's the deformity you see. So the transverse plane, you can see that, any lay person can see it. The sagittal plane, the metatarsal actually elevates, and you get a glimpse of this on radiographic analysis when we look at this, but the frontal plane was really the key. The literature bears this out. When you look at work by Kim or Akuda, if the frontal plane deformity is not addressed, there's anywhere from 10 to 12 times likelihood of recurrence or patient dissatisfaction. So this really is almost the missing link, so to speak, of bunions. And what Treace did was develop systems that take into account this triplane correction that's instrumented each time for this. We tried to take an approach that simplifies the process. So all of our options come down to 4 or 5 steps, and you can see through guided, instrumented systems, that created not only consistent results, but what it did was it took the variability of the surgeon out of it, good day, bad day, and where you train. You know, we were talking outside here with some of the investors, and really bunion surgery depended on where you trained, what part of the country you trained, what was prominent in that area, and then that's what surgeons did. Not necessarily the best option for the patient. And what we wanted to find was a best option for the patient that's consistent, and this triplane correction is what we came up with. In 2015, we started with an open technology. So we were around a 7-centimeter incision in order to use all the instrumentation in order to get this done. As we developed an understanding for not just the pathology, but also the instrumentation, we were able to take that incision smaller and smaller. And really, one of the main thrusts of this, how can we get the same triplane anatomic correction through a smaller incision? And it's the iteration of the instrumentation in order to do that. So as we started with 7 centimeters for Lapiplasty, we now can go to a micro-Lapiplasty through a 2-centimeter incision. We believe this is very important for a lot of reasons. The morbidity of surgery is something across the board, whether it be general surgery, vascular surgery, any part of orthopedics. The amount of damage caused to the body, the deconditioning, is really powerful, and it really matters. With the advent of these smaller incisions and minimally invasive surgery, we're doing less scarring, less deconditioning of the patient. So this is really a great iteration to start us moving forward. And then we'll talk about the fixation last. There'll be a dedicated slide, because as we went into instrumentation that allowed us to do these procedures through smaller incisions, we needed complementary fixation in order to fit through that procedure. The micro-Lapiplasty for Lapiplasty was the first advancement in this MIS technology. And 2 main things came out of this. One, what we call an external positioner. And so instead of that cup being put on the bone, we were able to do it on the outside of the skin. That alone lengthened the incision by several centimeters off the bat. And then the cut guide. The cut guide was narrowed on the transverse plane and thin, and what this allowed with a percutaneous approach, just the width of the saw to get in to make the appropriate cuts. Once we did that, complementary products came out, because now we had to retrieve the bone out of that joint in order to create the fusion. And so we have Lapitome, Razortome, and then speed release. And these are instrumentations that complement the MIS surgery, because when you're working through a 2-centimeter incision, that visibility and that ability to get the bone out that you just cut is critical. So we developed this, and then lastly, which will be coming up, we'll show a dedicated slide, is speed plate. The speed plate technology is really unique. I'll save it for the slide on this, but why this was developed is because as we went through these smaller incisions, we needed an implant to fit through these smaller incisions with the same load to failure and cycle to failure as the traditional plating. At this point, we've had thousands of patients treated. We had published papers. We had the data. So we needed to recreate those same results through a smaller incision, and all this instrumentation helped to do that. You'll see several instruments here, like an incision guide and some release tools that we'll talk about. But what we noticed early on is to do these procedures, through the smallest incision possible, you had to really know where you were anatomically on the foot because that incision mattered. If you want to go through a 2 centimeter incision and you're a 0.5 centimeter off over top of that joint, well, by definition, you're already at 2.5, and that wasn't the goal. So for this and adductoplasty, we have incision guides for this. So dedicated instrumentation in order to do the same triplane anatomic correction at the tarsal metatarsal joint. You can see the size of the guide. So that became the rate limiting step, is how do we do this same procedure through this, and it developed into this system. That leads us to speed plates. The speed plate technology is really fantastic. Mark will talk about the speed MTP. This is where this kind of comes from for the first MTP fusion. But the idea was not only did we need an incision smaller, we needed fixation to fit in that incision. And then for efficiency, how do we get this plate and 4 screws in as one monolithic structure? And then what was developed was 4 tines that act as those screws that go in all at once, and then we lessened that to a 2-tine speed plate and then a micro quad. All that is to create the stability we have with biplanar plating with the traditional plates and screws, but allow that circumferential stability. This is very unique because it functions as a plate. It goes in with the ease and efficiency and the compression of a staple, but it really is designed off of our traditional 4-hole plate, 4-hole plate and screws. It does not contain nickel, and it's anatomically contoured. The anatomic contour allows us to be placed on the bone segments where we want it without impeding into any of the soft tissue structures like the tendons, without impeding into the surrounding joints. So this has really been a iteration that has transcended Lapiplasty, adductoplasty, and first MTP fusion. These plates are even used in hindfoot, midfoot fusions, fractures, these sorts of things. So this is really good. When we look at our triplane correction through a small incision, you can see the pre-op, the post-op, and then the clinical image. And again, the goal was a triplane correction like we had through a smaller incision. You see the incision there, the lack of length on the incision, the lack of swelling within that area. If you compare and contrast this to our traditional open, you see on the right side there was a traditional open incision with maybe 7 centimeters, and then we have our 2 centimeter Lapiplasty. And besides the skin, obviously you have the less trauma to the tissue. The X-ray is what I want you to focus on for one reason. We wanted the same triplane consistent approach through a small incision, and we were able to capture that with micro-Lapiplasty. So that's really the key to this. So that is Lapiplasty in the iteration through micro through the 2 centimeter. As we move on, metatarsal adductus. Metatarsal adductus is a very important condition with bunions. We'll get into statistics in a subsequent slide. But one of the things we realized as we were able to dial down the what we call intermetatarsal angle or correct the deformity of the big toe, we were getting down to 0 to 4 degrees. And there was a subset of patients that even if we got down to 0, they still had a deviation of their toe, and it looked like clinically they still had a bunion. And this is a subset of patients. It's called metatarsal adductus, and I'll show you a slide on this. In a traditional bunion, just the bone behind the big toe, called the first metatarsal, is deviated out of alignment, and for that we have 3 offerings of triplane correction: nanoplasty, percuplasty, and Lapiplasty. With metatarsal adductus, the 2 midfoot metatarsals, the second and third, also deviate with the first. And that creates an entire midfoot deformity. And you can see, you can make an argument that the space between the first and the second metatarsal, the long bone behind the toes, is not really increased. But yet they have a clear deformity and a clear bunion. So we needed a system in order to do a triplane correction with consistency in order to fix that. Before adductoplasty with Treace Medical, this deformity was just overlooked for the most part. There was no consistent way in order to correct this. So you can see that the deformity in the foot, both radiographic and clinically, still persists. And what that does, that leads to very dissatisfied patients, to say the least. The number one question that we got is, well, who needs adductoplasty? When do we do it? Who has metatarsal adductus that we need it? And we came up with a system called a plumb line. We published this in 2023. The second author that's not on here is very famous. Thank you, Sean. But the idea of this is we took a line from the medial midfoot bone called the cuneiform and extended that laterally where the first metatarsal would line up to the cuneiform in a corrected position. And if that line did not touch or cut into the second metatarsal, that's what we call plumb line negative. That means we have enough room to correct that first metatarsal with nanoplasty, percuplasty, or lapiplasty. In contrast to that, and this is the animation going over. In contrast to that, you see the foot to the right with metatarsal adductus. We draw the same line and extend it, and it crosses into the second metatarsal. And this is very intuitive. Patients understand this immediately. Most importantly, other surgeons understand this immediately. And if you look, if I correct the first metatarsal into its anatomic alignment, the first and second metatarsal compete for the same space. So we physically do not have the room in order to do it, so we have to consistently move the second and third metatarsal out of the way, and then we can go forward with the first metatarsal for its anatomic alignment, hence the birth of adductoplasty. And what that came out of, 4 steps, just like the lapiplasty, where we prepare the joint, cut the joint, compress the joint, and fixate the joint. And again, this takes a very complex midfoot deformity that had no real consistent answer, and it made it streamlined and consistent with the results. Just like everything else, this started out as a full open procedure, about 7 centimeters, and then over time, as we learned from doing the procedure and understanding instrumentation, we can get this down to a mini adductoplasty through 4 centimeters, and a lot of times that could even be 3.5. That is my take, not Treace Medical. So what we realize is we don't have to cut both joints at the same time, and then you can see the instrumentations. Just like every iteration of the instrument or the system, instruments followed to complement the procedure. We have to have a robust release between what's called the base of the third and fourth metatarsal, hence the tritome, which is a single-use instrument, and then there's multiple guides. And what's unique about the adductoplasty is we also have single and double, no deformity of the midfoot, just primary arthritis. So we have a guided system to fuse in isolation the second or third, just for midfoot arthritis, which is also very common. You saw the speed plates at the end. The incision guide is a consistent theme. We have to be in the right spot so we know that our incision stays within the boundaries of the length that we want. You see the guide was reconfigured, so it's the same transverse plane and cut angle. It's just reconfigured in order to cut one side at a time, and then you can see the results. And the idea is the less trauma to the surgeon. You have a 3.5, 4 centimeter incision, a 2 centimeter incision that handled a very complex midfoot deformity. And it handled it with a guided system with minimally invasive approach to it. So really fantastic, and you can see how the skin heals and how the foot looks afterwards. So those are our 2 flagship, so to speak, procedures of lapiplasty and the iteration of such, and adductoplasty and its iteration. And then my fellow colleagues will go over the rest of the systems. But I appreciate your time and attention to this. Thank you. Now, introducing Mark. Okay, Dr. Mark Easley from Duke. He's not limping. He had knee surgery.
All right, thanks. Yes, I'm Mark Easley. I'm at Duke, and with my colleague Jonathan Kaplan, who's here as well. And I'll try to talk to you off this thank you slide. Is there something I just advanced and it's good? Yeah. All right, so bunions are very common. I think you've got that. And what I'm going to talk to you about is arthritis, or when the white shiny surface starts wearing away on the big toe joint. So I'm looking at the category, Will already showed you this, but I'm looking at the category that's all the way down at the end there. So that one there, where we're talking about what do you do about this arthritis, and you think, well, arthritis, you have knee replacements and joint replacements. Well, for the big toe joint, we're not there yet. So what we typically do is a fusion or mending the joint together. And you think, wow, you're going to fuse that joint together? Then how is somebody going to walk? If you don't move your big toe joint? That's what we what we're going to talk about. It's a very common problem. So there are tens of thousands of bunion surgeries done in the U.S. Every year. And this problem is a close second. So arthritis of the big toe joint, there's thousands and thousands of these operations done, these fusions of the big toe joint. So what is Treace Medical going to do? I wasn't one of the founding surgeons to work with Treace. I actually approached them and said, I'm starting to do your operation. I love what you do. Could I somehow be involved? And they invited me to be part of the team because it's the right way to do it. And what I want to emphasize today is there are all of these instruments you'll see and these cool products, and they are important. But what Treace does really well, and the surgeon advisory team does, it's really the philosophy of how to do the surgeries. And if you look at other products on the market, they typically roll these out with the screws and the plates and say, okay, have at it. What Treace does much better, in my opinion, that's why I joined the group, or asked to join the group selfishly, was it's a philosophy, right? It's like the surge where they teach you how to do the techniques. Nobody teaches surgeons how to do surgery better than Treace Medical. And I am a consultant with other companies too. This is hands down the best approach to teaching surgeons how to do the techniques. And oh, by the way, we have some great instruments too that make that better. So that's the distinction there. But we're going to talk about arthritis of the big toe joint. So you can have a bunion, just like Will eloquently just showed you and talked to you about, but you can have it with arthritis. So Will or the others can make that toe as straight as they want, and cosmetically it'll look nice. But it's going to be incredibly painful because it's grinding bone on bone. We don't want that, right? So that's when we talk about doing a fusion. Now, there's a whole nother category which I mentioned, and that is the toe's straight, but it has arthritis. Again, an incredibly common problem. Tens of thousands of these done every year in the United States, and unfortunately not done exactly perfectly, but that's called hallux rigidus, just a stiff big toe, right? So this here, there are studies done that show that if you have a stiff big toe joint, you're very debilitated. But there are also studies that show if you fuse that joint and make it pain less, even though it's stiff, you're still incredibly functional. You can play sports on a big toe joint. You can run on a big toe joint that's fused. So it's not as though you're going to debilitate these people, as long as the toe is put in an anatomic position. So Will just talked to you all about the triplanar correction. These same principles apply to the big toe joint fusion. I don't think surgeons fully understand that, but Treace and the team really teaches that well and then provides you with instrumentation to do that surgery well. So this is a patient walking down you've been to the doctor's office, just walking up and down the doctor's office here, and you can see that it looks pretty natural, right? And you could even have this patient do some exercises or run if you want, but it's really hard for me to tell that that big toe joint's been fused. So as long as it's put in the right position, the surgeon's taught how to do this properly, and then you have instrumentation to make it fuse reliably and have them be able to walk on it right away because it's stable fixation, then you'll be a very natural and be a very physiologic. The competitors are out there. Look at this. This is all over it. MTP joint fusion is a very common orthopedic procedure. We do this on a very common basis along with bunion surgery. The problem is sometimes often the implants are very bulky. They are not necessarily taught the technique. Everybody knows how to say, yes, a common procedure, but there's some subtleties to it that need to be taught properly so it's done correctly. And so mistakes can be made. The toe's put in the wrong position, that's symptomatic and a problem. The plate's too bulky, it's symptomatic. There are ways around that. So what Treace does is take a common problem. Well, one you learned from Will, here's a problem that hasn't been defined. 130 bunion surgeries, we got to make this reproducible and more consistent. In this year, yes, a very common operation, but what Treace does well is innovate and make it better and make it reproducible. I work with residents and fellows, people that I train. Every one of them says, my God, this speed MTP, it is so easy and intuitive, and it's reproducible, and that impresses upon me. I just showed it to him one time and said, this is a system I'd like to use. In addition, there are other instruments like Will showed you that make the operation easier, that the competitors, yeah, maybe they have some of these, but usually you have to scramble in the operating room to try to find some of these things. These all come in the kit. So ways to make it easy to expose that joint that's already stiff, so it's easy to work in that joint. Ways to smooth the surfaces, because it comes with bone spurs, right? It's arthritis, going to make bone spurs. And then you have a system that with that speed plate concept, speed MTP, and a way to target screws so they don't interfere with one another. The way the tines work so that this plate continues to compress to make it more stable. And then a way to add screw fixation to pull the plate down to the bone and make this incredibly stable construct that allows the patient to walk on it right away. Yes, they have to protect it some, but it's not as though they have to get a knee scooter or they have to be laid up in bed. They can get back to their activities and for 6 weeks have to protect it, and then they can get going on this. Again, here are some of the instruments with it, but it's the same speed plate technology applied to the big toe joint. That's unique in the system, in the competitive market. And it's the principles of the technique and then having instrumentation to put this implant in properly and then have it work for you. And it's low profile. So see here, there's arthritis, so sorry about the graphic pictures. I know maybe some of you just had breakfast, but if you look here, it's bone spurs. You get the idea. We can smooth those down. This feather rasp idea, it can be applied anywhere, but really slick tool to make this easier so you can contour exactly the bone that has spurs on it so the plate and the instrument, the implants can sit perfectly anatomically on the bone. And then a targeting device, if you can imagine, if you're putting 4 tines in a bone, a little bone and just a big toe joint, and then you have 2 screws go in and you want to put 1 extra screw in for fixation, something's going to collide, right? And you just don't want that to happen. You don't want to slow down the process. You want it to be longer in the operating room than you need to. So targeting device, so that never happens. Make it a lot easier for you. So you can see here, sorry, pretty graphic, I know, but it could be worse. It could be worse. But this is what we do, okay? So we're sharing with you with what we do. But it's a way to make it easier to get into the joint. You see this little tool here. It's really, I mean, it's art. It's a medical art, right? So it's actually this is artist work, and that way these instruments can sit. This is actually one of my surgeries, so you can see here where everything sits nicely because we've contoured it perfectly. We positioned it. We taught the technique how to get the toe in the right position, and then it's step by step. It's real quick to drop these in, and then here's the implant. Sits in very nicely. And you can actually, it's so stable, you can just actually, we're carpenters. You can hammer this in place and then drop these extra screws in to give it really a nice fixation. So good. All right, there's more breakfast. Just have to be patient. We'll get through it. And you can see here, this is in the operating room. Then you can see how stable that is. In other words, it's stable. You can go right away and walk on this. Not dance on it, but you're going to go walk on it right away because it's stable. And here it is. Then the process of it's nice. It's low profile, low contour, and you can see around that implant to make sure the bone's healing the way you want it to without it being obscured by the hardware. Here's a bunion surgery. So bunion surgery, again, some other techniques. Not that that's wrong, it's just that sometimes those don't work, and this is how we salvage it with this same operation where we do a fusion. You can see the patient's incredibly happy. How do you know the patient's happy from preoperative to postoperative? How do you know? Quick. The toenail polish, that's exactly right. So it's good. Anyway, but you get the concept. But what I want to emphasize with you is that, yes, there's a lot of innovation and new things to take something that's complex, 130 different bunion operations, to try to get it down to something that's reproducible, predictable, and works for patients and works for surgeons. But then also something that's very established, a big toe joint fusion, again, a very common operation, but we can make it better. And what impresses me is that Treace puts the effort in to make that better. Holly, I think is next. Good.
All right. Good morning, everyone. I'm Holly Johnson from the Hospital for Special Surgery, right across the island. And I'm going to talk to you today about some of the more percutaneous options for bunion correction, and try to give a little background, but also give the thought process behind why Treace would enter this market. So we've seen this slide a couple times, and I'm going to address class 1. And this is where we have a fairly straightforward bunion deformity without adductus and without arthritis. And we have 2 new options for that, nanoplasty and percuplasty. So when we think about how surgery in general has gone from open procedures to more minimally invasive procedures in virtually every side of surgery, even open heart surgery, general surgery, and in orthopedics. And I think to make it the most relatable, everybody in this room has either had an ACL reconstruction, a knee scope, a shoulder labral repair, or they know someone who has. And if you think about those people in your life who've had those operations, it's all done through small incisions. And really, the entire market is going towards small incisions for obvious reasons. Decreased pain, decreased swelling, et cetera. Faster recovery. And so when we think about the advancements in arthroscopic surgery, it started from advancements in the technology and training that allowed every surgeon to do it. And at this point, I can't imagine a surgeon doing an open rotator cuff. It's just completely gone. It's off the table. That procedure is not done anymore. And I think that as we move forward in bunion surgery, we're going to go in that direction. So again, some graphic photos, but I think that it really makes the point that when we look at the foot on the left-hand side, traditional open procedure, and the foot on the right, what person in their right mind would ever want the surgery on the left? Honestly, right? There's not a single person ever who would rather have that surgery than the other surgery. So when we think about that and what's available out there, Treace saw an amazing opportunity to expand patient interest in surgery. So historically, and for those of you, there are probably some people in the audience who have bunions or have a spouse that has a bunion. Traditionally, even the primary care doctors say, you should never have bunion surgery. It hurts so much. It's going to take years to recover. It's never going to be good. Literally wait until you can't put a shoe on anymore. That is the worst advice because we know that from when a bunion starts, it continues to get worse over time. And as it gets worse, the toes get involved, the foot gets much more problematic, and the ability to fix the foot in a nice way is basically eliminated. So there's a subset of patients out there who want to have their bunion fixed, but they're afraid. And so now people are seeing, look, we've got these minimally invasive approaches that have less pain, faster recovery. I want that. And so they're coming into their surgeon's office and they're demanding those techniques, okay? And I'll say just anecdotally, I do no marketing. I'm not on social media. My hospital doesn't really do any marketing for me. I literally have to push. I have so many bunion patients. It's like they come because I operated on Susie, and then Susie's sister comes and sees me, and I do both of her feet, and then she goes and gets a pedicure, and then the woman who does the pedicure comes to see me, and it's just this circle of people coming in because they see a fast, painless recovery. So when we think about where we are in the country of the current state of bunion correction, it's a trade-off between patient benefits and technically challenging surgical procedures. So this is me doing the procedure on the left-hand side, this video. And basically, many of you may have seen it out there, but you have this power device with this, it's essentially a drill on it, and that's how you cut the bone. And the drill diameter is 2 millimeters. So I can cut the bone through a 2 millimeter incision as opposed to a more traditional way where you have to have exposure for the saw. It's a complicated procedure where I cut the bone, I shift the head, I put in wires percutaneously, meaning not through an incision, and then I place 2 screws, and that's what the foot looks like at the end. Those are the incisions, no incisions on top of the foot. And the problem is that it's really hard, and it's taken me a long time to become proficient enough to be able to do this in a reasonable time frame and to be good enough to really want to offer it to all my patients. So when we look at some of the x-rays that are out there, and I know that there's, I'm showing 3 different x-rays here. These are all percutaneous or minimally invasive bunion surgeries done really poorly. And these are people who even post this on LinkedIn and things. These are done poorly, and the patients aren't going to do as well. And so when these patients come in and they say, I want minimally invasive surgery, but I don't understand why everybody's not doing it. And the reason is because the surgery is really hard. And it's a difficult surgery to learn. It's a difficult surgery to teach. And if you think about how many you have to do to become proficient, it's anywhere from 40 to 50 when you're using the freehand technique. Most bunion surgeons may not be doing 50 bunion procedures in a year. So why would they want to adopt a surgery or a type of technique that's going to take that long to do it when they can do it the old-fashioned way? And maybe they don't get as many good results, but hey, they can do it. Well, the problem is that now we have this entire patient population that was never going to have bunion surgery before, that wants to have surgery, and we need to teach the surgeons how to do it. So this is where Treace comes in, and basically they've come up with 2 instrumented systems designed to dramatically reduce the learning curve of a 3-dimensional minimally invasive surgery. And so there are 2 options that address really, I think, two different surgeon populations. There's percuplasty, which is the screw technique that you saw me doing percutaneously, but now we have an option for a jig. And then nanoplasty, which is an intramedullary device, a plate system that surgeons can still do with a saw if they don't feel comfortable with the burr, but they can do it through a very small incision. And so with the percuplasty, it's a few very small poke holes in the skin, and with the nanoplasty, it's one singular centimeter and a half incision. So again, thinking about, well, does minimally invasive surgery work? Well, we know it works. There have been multiple studies that show that you can get rotational correction. You can get that three-dimensional triplanar correction using the minimally invasive system, and you can have successful outcomes. And there are multiple studies that have come out over the last 5 or 6 years that show excellent short-term and long-term results with this distal osteotomy technique. And now, of course, we have these patients coming in who want the surgery, and we're going to develop a system that's going to allow the surgeon to do it better. So if we think about the percuplasty portfolio, there are three aspects to it. So there's a three-dimensional correction and targeting guide. And this is where I would say for Treace, it was better to be a little later to market. And so there are other jigs that are out there on the market now from our competitors, but honestly, the jigs just don't really help the surgeon. They're very bulky, they're difficult to even get on. They don't get that three-dimensional correction. They're only correcting the bunion in two planes. And if you recall where Will DeCarbo was talking about how you need to get that rotational correction, none of the jigs on the market other than Treace correct for that three-dimensional deformity. So you can get the correction where you want it. It makes it very simple to place the screws and essentially makes the procedure much more boilerplate, which goes along with Treace's mission. There's a plug-and-play MIS power system that you can bring into any ambulatory surgery center, into a hospital, that makes it simple for any surgeon to have access to the burrs, and then the screw system, which is pretty unique as well. So looking at the targeting guide, you're essentially making those same incisions. You're sliding this guide in, and the jig or the guide itself helps you to dial in the shift of that metatarsal head, but then also rotate it to get that rotational correction, that triplanar correction. It holds it in place. And another advantage of this jig is it's essentially hands-free. So a lot of times when people are doing the bunion corrections, they need two hands. They need somebody to hold the correction and another person to fire the screws. This jig allows the surgeon to do it single-handedly. You place your wires and then very easily place the screws over the wires. When we think about the screws themselves, the heads are beveled, which means they're angled and they sit flush against the bone so that you're not feeling those screws through the skin, and there's a much lower rate of hardware removal. They have a self-drilling tip, and what this does is it makes it so you don't have to drill the bone over the wire, and it basically just simplifies the entire workflow, and you save time in the operating room and effort. And here's the screw going in. So thinking about case examples, this is an example of, I don't know if you can get the sense of shifting the head, putting in the screws, and then at 6 months, and yes, this patient has had a pedicure because they're quite happy, and that's actually a sign of a successful surgery, I agree. So just addressing the market that's out there, we have two populations of people that we're capturing with this new minimally invasive technique. We're capturing all those, largely women who've been afraid to have bunion surgery in the past because of the pain and everything else. And I will say, from a pain standpoint, one of you asked me earlier about pain medication. My patients take no narcotics after surgery. And if you think about the historically where bunion surgery has been described as very painful, this is not a painful operation anymore. And then we're addressing the surgeons who need to learn the technique. And we've got a great solution. Thank you. Jonathan.
Hi, everyone. I'm Jonathan Kaplan. I'm also from Duke University, like Mark Easley. And I'm actually going to leave this slide up for a second before I go on because I get to talk about the nanoplasty, which I like that it's in the middle because I'm kind of giving you the best of both worlds. And I think that's something that's a nice feature for most of our surgeons that are doing these procedures. And so, like I said, this is who I am and where I'm from. And really, you've seen this over and over again, and there's a reason we're showing you this slide repeatedly because it really does make sense. It helps surgeons develop an algorithm for their approach because historically, like Will talked about, most surgeons did what they learned, what they trained, what was in their area, and that's not really a good way to practice medicine. We want a way to sort out what patients need different procedures so that we can have more predictable results. And I'm, like Holly, going to talk on the mild to moderate deformity, these distal osteotomies, and specifically I'm talking on the nanoplasty, that medullary system. And so why are we talking about this in general? So again, these are instrumented systems that accelerate the growth, accelerate reproducibility for our surgeons, and we're decreasing the recovery for patients. And what are the challenges with the osteotomies? I think Holly did a tremendous job explaining it so well that I don't have to hammer it out. But even admittedly, I'll say these are hard procedures. Holly and I have been doing them for many years at this point, and we even struggle still, right? And so think about the average surgeon who's not doing hundreds of bunions a year. It's going to be hard for them to adapt a procedure that is technically challenging, that they struggle through the surgery, they have unpredictable outcomes, because at the end of the day, we care about our patients and we want our patients to do well. And so these are those black diamond procedures, and we're bringing them into that beginner. We're going to see them go into the green target that we want. And these are accelerating that recovery and accelerating the MIS procedures. And Holly talked about it. Why are MIS procedures important? Well, we see this. There's good data that shows patients have less pain, less risk of wound complications, less swelling, shorter recovery. That's what patients care about. And then there's surgeons, and surgeons want precision, they want adaptability, they want accuracy. They want this to be more streamlined in the operation so that they can have a better outcome. And that's what these systems do. Now, the nanoplasty specifically kind of meets surgeons in the middle because you've seen Will talk about the open procedures where we're using saws, we're looking at everything. That's something that surgeons are used to throughout their training. At the same time, Holly showed an example where she's using a burr. A burr for us, Holly and I, is very natural now, but it's not necessarily natural for the average surgeon who doesn't have experience. And so the nanoplasty allows surgeons to use a saw through a very small incision, allows them to be accurate, and then use the instrumentation to correct the three-dimensional deformity where they want it to be. And hopefully you'll see that as we go. This is a comparison of what these look like. So an average bunion surgery done open is usually as small as 3 centimeters, can be up to 7 centimeters in size, whereas with the nanoplasty, consistently it's 1.5 centimeters. But then the other thing you don't see in this, but you'll see in the next slide, and I know Mark said, you're eating, so just a forewarning. With the traditional procedure, we're actually having to lift all of the soft tissues. So not to be too gory, imagine we have to lift everything off of the bone to be able to see it and do what we need to do. And logically, it makes sense. That's going to be more painful. It's going to have more swelling. It's going to have a longer recovery. That's why these horror stories exist with patients. That's why for years and years, patients have been afraid to have bunion surgery. Whereas even with the nanoplasty, it's 1.5 centimeters, but you don't have to lift the soft tissues. You're working through this nice little pocket, and you're able to do everything through that small incision. So this is what it looks like. You can see the comparison. I won't leave this up too much so nobody gets nauseous, but that's the difference there. And this is what it looks like in recovery. Now, this is what patients see, right? They're not looking at their surgery. They're not watching their surgery, so they don't see that open picture, but they do see the after effect, right? And the things that they're looking at. They're looking at the alignment of their nail, like Mark talked about. And then when you take the dressings off, they're looking at the size of the incision. And you can see the difference here. The picture on the left, it's a large incision, but not just the incision. You see bruising tracking down the toes, tracking up the foot. Patients can see that. Whereas with the smaller incisions, really what sticks out on the picture on the right is actually our surgical marker. That's purple lines that we draw in the anatomy. You can barely see the incisions, and you see less swelling, and patients are happy about that. They can get back to life quicker. So what does the nanoplasty do? Well, just like everything else, it's step-by-step, it's instrumented, it's allowing a three-dimensional triplane correction. And so the first step is we're going to have a precision-guided cut with a saw, which again is very natural for most surgeons. We're able to insert the jig through that small incision, and we're really able to work through that small incision. We're able to correct all 3 deformities. So we're able to translate, meaning we move the head over into a position that we want it to be. We're able to angulate it, so looking from the side, we're able to get it lined up well. And then really really that third plane that is absolutely critical is the rotation. And you're able to dial that in. And it's possibly my favorite part of the procedure because it's very precise and accurate. And you're going to see an example of that in a second. And then we're able to fixate it. And the key with these minimally invasive procedures is we don't want to compromise outcome and we don't want to compromise recovery just to have smaller incisions and less swelling and less pain. And so that's what these do. They're really strong, stable constructs, allow patients to walk right away, allow patients to maintain good alignment. Because at the end of the day, the patients are looking for three things. Number one, they don't want their bunion to come back. They want predictability. Number two, they would like to have less pain with the surgery, with the recovery. And number three, they'd like to get back to life quicker, have a quicker recovery. And that's what this does. And so this is what it looks like on an x-ray. The first picture on the left is where you can see our cutting guide. So we're not just randomly making this cut. Surgeons can see on an x-ray where the cut is going to be. And again, they can use a saw that's very familiar and natural to them. And then in the middle picture, we can see we're inserting that guide. And I'll bring your attention to the middle and then the third picture because there's a pin that you can see coming in at an angle on the metatarsal head. And then in the third picture, you see that it's up and down. And what that's doing is that's essentially rotating. That's giving you your three-dimensional rotational correction. And we'll show you an example what that looks like in a second. And then this is our fixation on the right. Now, what I didn't talk about earlier, but I'm going to point out here, is it's also very low profile. Because what we don't want to do is we don't want to remove the patient's bony bunion, meaning their anatomy, and give them a metal bunion, meaning give them hardware that's prominent and palpable and symptomatic, where they have to go in and have another surgery to take it out. That's why Holly talked about the beveled screws being low profile, and that was the goal with the nanoplasty as well. And you can see that. And so again, this is probably my favorite part of the procedure, which is the rotation. And essentially, it's very precise. Notice how we're just gently dialing it in. We're just turning in a controlled fashion, and we can be very, very accurate getting our rotation. So we're not trying to get it in the ballpark. We're getting it exactly where we want. We're essentially hitting a home run. So this is what it looks like through the recovery. The picture on the left is preoperatively, where you can see that they have an angulation in the bone. The picture in the middle is immediately postoperatively, where you see the fixation. And a lot of people ask me on the drift and try not to trip. A lot of people ask, does it really heal in this area? And that's what we've seen over time, over the years. You saw that with Holly's examples, and you can see it on the right, where all of that is new bony consolidation and new healing. And a lot of patients will also add something called an Aiken osteotomy, which is we'll do an osteotomy in the proximal phalanx, and that's where the percuplasty can come into play as well with this. So really it gives you a comprehensive portfolio, a comprehensive package for these patients. And then this is another example, and I like this one because you can see the clinical photo on the right, where you're looking, they're about 3 months postoperatively. Common theme, their nail polish is done, they're back in regular shoes, they're running, they're active. You can barely see the incision, you're really just looking at the skin folds. And so it's really nice. And then imagine that's looking directly medially or from the inside. Imagine looking from the top, you can't see any incisions at all. A lot of our patients will come in at 3 months and say two things. Well, three really. One, when can I do my other side? Two, I sent a lot of family members to you. And three, most people don't even know I had bunion surgery. And I think for us, that's important, right? That means they're happy. And so this is really kind of combining the best of both worlds. And again, it closes the loop, giving you a really comprehensive portfolio, but in a really nice algorithmic approach. So we're not guessing how to treat bunions anymore. Again, I'm going to bring Mark Easley, my partner, back up to talk about the IntelliGuide.
All right, sorry you stuck with me one more time. This is good. So I do have a question for you. How often do you go to a meeting and you're not prepared? Can I see a show of hands? Really? How many want to do that? You really want to be prepared. Okay, good. Okay, one. All right, that's good. Spontaneous, off the cuff. But what I love about this, so this is patient-specific instrumentation, okay? So PSI, and we're talking about, we really can talk about all of these things with this, but we'll focus on really these two center ones. So that Lapiplasty or the Lapidus type procedure where the first ray, that bunion's corrected, or if you have that adductus problem, you have to correct as well. So that's what we can address. So what's the difference here is that we can actually go to the operating room now with a plan in place. So we're not winging it. We're not seeing what might happen. We have a predictable plan going into the surgery. And this is not new in orthopedics. This is not new in surgery. This is a lot where surgery is going, that we have the technology now where we can actually plan things ahead of surgery and then go in with that plan and execute that plan. So here it is. We use a CT scan, so a CAT scan, so it's a three-dimensional way of looking at x-rays. I know that, or the foot, and I know that before it was mentioned that one of the mistakes is looking at bunions in particular in 2 dimensions. I'm also a total ankle replacement surgeon, and there are very few total ankle surgeons now that do total ankle replacements by winging it or just guessing where it needs to be. We're pretty good at that, but we can use patient-specific instrumentation, a CT scan, to put those components, those metal pieces in, just like hip or knee replacement, in the proper position. And so we can do that now with bunion surgery too, and that's again that innovation that Treace brings to the table of looking at how can we predict this ahead of surgery. What you see all the way on the right, after the CT scanning planning has been done, is actually these cut guides. So you saw a lot of different cut guides and a lot of different instruments today, but same principles applied, planar is in place, and guess what? The cut guide is not being put on and we're looking at a fluoroscopy or that live real-time image in the operating room. We actually put the cut guide on that's pre-made for that patient. So we have that, that's a little model in the operating room, so you get the haptics, if you know what that is, right, where you get a feel for that model comes sterile in the operating room. You get a feel for how that sits on the bone. You can look at it even before the surgery starts. This can be sterilized, and then you take that and put it onto the patient. So it's a patient-specific guide because it's going to make the cuts then, as long as you position it properly, exactly where you need it to be to get the correction you already planned. So this is really looking innovatively into the future, where to go. Really old slide of an old type of ankle surgery that was done freehand for emphasis, really. And there are ways we can do this with instrumentation ankle replacement surgery, and that's what I was talking about before. There's a patient-specific guide. So surgery has been planned. Where do we want to make the cuts in that ankle bone so the component sits exactly where we want it to be and we're not guessing or trying to fiddle with it in the operating room to try to get it right. Same thing for bunion surgery. So where can we use this? What can be just a straightforward bunion. It can be that metatarsus adductus bunion. It can be a bunion or a foot surgery that's been previously done and potentially not done well, or there were some complications. And we can correct that as well because we can make a preoperative plan and decide how to do it. So here it is, right here, we got the cut guides based on 3-dimensional analysis. And this can be personalized, I like that word, but what it really is going to your meeting, having planned for the meeting, knowing exactly what your strategy is going in, and knowing what the end result's going to be because you've planned it ahead of time and you're going to execute it based on patient-specific instruments for that, which I think is terrific. So you see that here, all these measurements mean something to us, but you can understand that we can take a computer now and do all this so we don't have to do all the heavy lifting with calculations. It can do it for us. And what we really want to end up with is a plan like this. So here's the preoperative x-ray. Again, we're looking under the skin. So here's the x-ray. You've seen a lot of this already. And what we want to end up is where the green is, right? And that's in 3 planes. So we're going to move that. We're going to correct the bunion. If for some reason we have that metatarsus adductus, we're going to move those other metatarsals out of the way. We'll put the bunion where we need to be. We'll correct that in 3 planes and get the rotation exactly where we want it to be. And we can tweak that, but it's all done before we ever step foot in the operating room. And here are these patient-specific cut guides. So the beauty is that the Treace team is available. So if surgeons want to do this, say they're a little unfamiliar with this potentially, the Treace team will sit with them, with the engineers, and go over the plan with them. And little tweaks are made, and there may be some surgeon preferences, and those can be all built into these cut guides that are patient-specific, specific to that particular patient for that particular bunion deformity. But the big picture is that that's a reproducible technique that can be done over and over and again. And I think if you look 5 years from now, 10 years from now, this is where it's going. It will be even more innovative, and Treace will continue to be at the forefront. But the idea is that we're pushing this forward where it's very predictable, and I don't have to do all these little adjustments because I already know where I need to be. I just have to put the guide in the proper position and make the cuts and then finish the operation from there. Yes, some more graphic pictures. Maybe Holly would be disappointed in me because, I actually made an incision. But you can see here that it's a patient-specific guide. But I can look at a preoperative plan, put it on, look at the fluoroscopy image, and confirm that's where it is. Ideally, we get to the point where we just know where it's going to sit. We wouldn't have to look at the fluoroscopy until we're all done with it, right? That's where the evolution's going. Again, a little more invasive here, But the idea is a cut guide that's made specifically for that patient. And yes, we can start making those smaller and smaller and smaller incisions for that as well. But we're at the forefront of this right now working forward. You can see here this rotation. Remember the rotation? So think about it. You can put this cut guide on, and here for the bunion, for instance, and you see how right here we want to make this cut and we want to make this cut, and that's going to help correct the bunion, but also the rotation is built in it. But can you see that these two I can see down these pinholes, but I can't see down these. Here I can see a little bit better, but what's going to happen is I'm going to make all these cuts, and these pins will be in, and then I'll put another device on that actually just locks in, and it takes those two pins and rotates them in alignment and drops in, and then that corrects my rotation. So I don't even have to think about it. It's already all pre-planned to make that a lot easier. And that's for the adductoplasty as well. But you can see the pins are offset. When I put the next guide on, it drops them in, the rotation's already done, based on my preoperative plan before I ever stepped into the operating room, as I said. So here's the correction. You can see that. The same implants, those are important. But what's really important, I have a way of reproducibly doing this operation and plan it all before the surgery. And what if you have this situation where somebody has just physiologically has a short first metatarsal? Well, as you can imagine, there could be some problems if the foot isn't balanced properly. Well, I can actually address that. I can, in my plan, say, okay, I got to lengthen this bone this much, and I can plan that exactly how I need it to be. That right there all the way on the right is some bone graft. So there are donors out there. You can donate corneas and hearts. You can donate bone, too. And these are pre-cut. Treace has these, too, so the surgeon doesn't have to sit there with a saw and try to get it just right, and a lot of tailoring has to go into it. It's already pre-made for this particular problem in different sizes. Yes, it's human bone, and then that is immediately available and can drop in so I can make up for that deficit in length and address that with the same type of fixation, but all pre-planned, and that's the difference. So again, I think what's amazing about this, and I really think this is where it's going to go, is that all this can be pre-planned. Think about how predictable that is. When you go to your meeting, you feel very comfortable going in because you have your strategy, your plan of attack, and you know what the result's going to be because you're prepared. And that's the big difference. So all of this can be done, but with a pre-planning in place, patient-specific instrumentation. Thanks. That doesn't work. Sean, you have to introduce yourself.
Okay, good job. All right, thank you, Dr. Easley. Okay, that's loud. I'm Sean Scanlon. I'm Chief Innovation Officer at Treace Medical. I've been at Treace since just about the beginning, and I like to say I have the best job in the world. I get to work with a company, joined John Treace very early on, that has invested in innovation since day one, and we're still accelerating our innovation. We work with surgeons that are super talented, visionary and pioneers in MIS, Lapiplasty in this field. And then we have a mission at this company that is very clear, and we went through it a lot today. It's how do we bring triplanar correction, how do we democratize it for all surgeons in order to improve bunion surgery? And we've done this through highly instrumented techniques that we can take a surgeon, do one training lab, and they can get out and get a great result in any of these procedures. And we've worked hard over the last couple of years of how do we expand this three-dimensional correction to the osteotomies, to MTP fusion. And this is really a coming out party for us this year as we launch this full system. We also have these enabling technology platforms that we talked about through the different talks. And these are things we're going to continue to build on as we grow the company. So where are we going to play? How are we going to continue to grow? We talked about the bunion opportunity. It is still a massive opportunity that is underpenetrated. So through our open procedures, Lapiplasty, Adductoplasty, and then as we go into MIS procedures, we think we can move further up the funnel, as we talked about, bring more patients in that are on the fence for bunion surgery, and expand through penetrating the bunion market. We're also going to use some of these core kind of technology platforms to expand the market and grow within the market too. There's a lot of adjacent procedures with bunion surgery. There's 28 bones in the foot. There's other common pathologies associated with bunions. So how do we become one-stop shop with the best instrumented systems for all the different pathologies the surgeon needs to address in the bunion case? And so 5 growth drivers, and this is a bit of a summary of what I just went through, but number 1, continue to advance our core procedures and penetrate the bunion market. 2, we're going to expand our portfolio into these other highly adjacent procedures with bunions And we're going to do this by growing our three main platforms, our MIS systems, our SpeedPlate platform, and then also scaling the PSI digital solutions that we're working on as well. So this first thing is something that you've seen a lot today and something that we're super passionate about. So by being highly focused on bunions, we can continuously be very close to our surgeons and in these cases and become experts in these procedures and look at the unmet needs in the procedures to continue to make them better. So I like to call it kind of, John mentioned kind of the iPhone model. We're always working on the next iPhone on the core Lapiplasty, Adductoplasty, and now the MIS and MTP systems. How do we make them easier to use, more reproducible, and then provide less invasive options for them as well? And you can see an evolution. There's actually like 12 different versions of Lapiplasty over the past 10 years. And this year, we're actually launching at the end of the year a limited release of our Lightning system, which is a way that really integrates Lapiplasty with SpeedPlate and makes it a truly hands-free system that's really conducive to the speed and efficiency of SpeedPlate. Also, as we've kind of been deep in these procedures and kind of attention to detail around, what are the other unmet needs in the procedure? How do you make these procedures more efficient, faster, and improve outcomes? And we've talked about a good bit of these single-use instruments. These are all highly unique to Treace. These are procedure-specific. They're problems we see in the case, and how do we make the case go better? Examples are, we talked about a little bit, lapitome. You make a small incision, you make a bone cut. How do you get that bone slice out of the small incision without breaking the bone and having to dive in and pick it out? This is an osteotome, like a little chisel, but it has a hook on the bottom, so you release the bone, and then you can hook the bone and pull it out. The speed release is common to do it's called a sesamoid release at the big toe joint when you're doing Lapiplasty. We saw surgeons just using a scalpel, and many of them would spend about 5 minutes digging around in there blindly trying to do the release. We found a very incomplete release affecting our outcomes. So how do we make a guided instrument that allows them to do that release very efficiently? So both improves the speed and efficiency of the case, but also it leads to better outcomes. And these have become a large part of our kind of revenue base in these procedures too. And once surgeons try these, they can't go back to doing the cases without these tools. They're such great problem-solving tools. All right, so the second part of this is expanding our portfolio. And so like I mentioned, there's 28 bones in the foot. There's a lot of other common pathologies associated with bunions. And so how do we take our recipe of highly instrumented techniques and address these other adjacent procedures too? And we're just getting started into some of these different areas. And a couple examples here, you saw in some of the cases an Aiken osteotomy, which is an osteotomy to help straighten out the big toe joint. It's commonly done in bunion surgery. So often use a staple for this. Many of the staples in the market were very blocky, very prominent for the patient. So we're able to use our SpeedPlate technology platform and make a very low profile staple. You can see how well this staple fits to the contour of the bone. And then we also mentioned bone grafts. And so other procedures in the foot, flat foot, other things that we're moving into, how do you address those? And so we're able to use our SpeedPlate platform you see in the bottom right, bone graft, to both lengthen the first metatarsal, but if you look in the back of the foot, that's actually in the heel, that's an osteotomy to address flat foot. So these are areas we're going to continue to build instrumented systems, train surgeons on, and bring these solutions to help kind of really be one-stop shop for everything that's performed in a bunion case, in addition to our core procedures. All right, so the third thing, and we spend a lot of time today, I'm really excited about MIS and where this is going. And so how do we accelerate access to MIS? These are challenging procedures like we went through. How do we take our surgeon base, the majority of them are not doing MIS, and how do we help train them and give them the tools to be very proficient in MIS after just one surgery? And you see a stat here. This is the fastest growing area of bunion surgery when we pull our surgeons. MIS is also used in many adjacent procedures throughout the foot, so against a platform as we move from bunions, also throughout the foot to other pathologies. And there's two really main limiters here, in addition to the training. One is, we talked about burrs. So a low-speed, high-torque burr is used for MIS surgery. This is a capital piece of equipment. How do we provide access to surgeons and they're able to do this? So we are announcing today a partnership where we can have a really plug-and-play MIS system that's dialed in for foot and ankle surgery, where they just plug in the handpiece and all the settings are pre-ready to go. And this is highly scalable for us in a very capital-efficient way to address MIS power systems. And then the other side of MIS is, how do you make the instrumented systems like we talked about with nano and percuplasty that the surgeon can go to one lab and get a great result in their first case. So we're going to continue to iterate and expand on MIS and grow this throughout the foot. And then the fourth thing is expanding on our SpeedPlate platform. And so we've also covered this a bit through many of the talks, but this is a highly differentiated implant platform that only Treace Medical has. And the benefits are surgeons love nitinol staples have been in the market. They love the dynamic compression of nitinol staples. They're fast and easy to put in. They like the compression. But if you look at the data in the bottom right, this is some head-to-head testing that we did of our titanium SpeedPlate versus nitinol staples. Titanium is much stiffer, so you get a lot more compression from titanium, kind of pound for pound, and then it's much better in fatigue. So as the patient walks, you can see the cycles of failure of a SpeedPlate in the bottom right, the red bars versus nitinol. It is much better in fatigue, so patients can weight bear faster with with our titanium SpeedPlate technology. And then the other benefit, and we talked about how do we get into small incisions, is that we can actually do highly anatomic shapes and machining of titanium that you can't do with nitinol. So things like the microquad would not be possible with nitinol. We can do it with titanium, make a very robust fixation through very small incisions. Then we're also expanding with SpeedMTP into this hybrid fixation, which combines the best of both worlds. So you have the dynamic compression of SpeedPlate, but then you also get the locking screws of a typical plate. So that gives off-angle support and stability, so that makes the SpeedPlate even more stable. So as we look at these other pathologies in the foot, and as we continue to advance our core procedures, but also these adjacent procedures, SpeedPlate is a platform that we're going to be applying throughout the foot where we can make very anatomic designs in order to address many different pathologies throughout the foot. All right, and then the fifth one is PSI and other digital solutions. So Dr. Easley did a great job of, who wouldn't want a personalized solution to go in as a surgeon and to be able to communicate to the patient, here's your anatomy in 3 dimensions, here's what I plan to do, and know what the outcome's going to be, pre-planned before you step foot in the OR. And so the challenges that we're planning to address here, and we've been investing in this area a lot, is how do we bring software solutions and AI into this in order to make this highly scalable for Treace and for our surgeons, and also just make it accessible for all surgeons out there. So how do we make the process easier, smoother, less costly, so that we can expand this throughout the entire bunion surgery, which is a much more common procedure than something like, total ankle we talked about. So super excited about where this digital technology is taking us from both a surgeon and intraoperative guidance, but also as a patient communication tool to help educate patients of what their pathology is and why they need bunion surgery and what the reconstructive plan is. So those are the 5 growth drivers that are continue to grow Treace Medical as we expand from where we are now to kind of doubling the size of the company in the next several years. And that is all. Thank you, and we're going to take a little mini break and then do a panel Q&A.